Hello everyone, in this video we will discuss about paracetamol overdose. The paracetamol is the non-steroidal anti-inflammatory drug. It is usually taken for fever, that is antipyretic, and for pain, that is analgesic. This is the most common OTC drug available in our pharmacy and the market. So there is the risk of overdose. In this video, we will discuss how to manage paracetamol overdose in emergency. If some patient came with the alleged history of deliberate self-harm with paracetamol overdose, meaning more than 150 mg per kg or more than 7 to 8 grams of the paracetamol, then we will treat like this in emergency department. Now let's go through it. For example, if the patient came, then we should initially check the vitals of the patients. We should check the airway, breathing and circulations. We should take the history and take when the paracetamol was taken. If it was taken within 1 hour, then we can do gastric lavage, or if the dose is so high, then we can do gastric lavage. Otherwise, there is no role of gastric lavage. And we should check if it is taken with any other drugs or any other food or alcohol or not. If it is taken with the alcohol or any other drugs like TCA, then it should be taken in the mind. We can check the lab paracetamol level if it is more than 4 hours, and we should check the baseline along with LFT, INR, create, glucose and ABG. If it is more than 4 hours of the post injections, then we can check the lab paracetamol level, and we can use the Rumac Matthew nomogram for the initiation of the antidote for paracetamol overdose. If it is above the line, then we can start the NAC. NAC means N-acetylcysteine. If it is below the line, then we can observe and recheck the labs. If it is unknown and late but multiple dose, then we can use the NAC empirically. The standard dose of the NAC and acetylcysteine is IV regimen for 24 hours. Initially, within 1 hour, we should give 150 mg per kg in 200 ml, 5% dextrose. And for next 4 hours, we should give 50 mg per kg in 500 ml, 5% dextrose. And next 16 hours, we should give 100 mg per kg in 1 liter of the 5% dextrose. We also have the oral NAC regimen, which is 140 mg per kg is the loading and 70 mg per kg every 4 hours. So total 17 doses is the maintenance dose. We can give activated charcoal if it is within 2 hours and if the patient is alert and cooperative. The dose is 1 gram per kg, maximum is the 50 gram. And we should repeat the lab every 12 to 12 hours, LFT, INR, create and all. We should check for the sign of encephalopathy, coagulopathy or hypoglycemia. The admission criteria: if the LFT and INR are elevated, symptoms or high risk of injections and delayed presentations, these are the indications for admissions. And we have got the King's College criteria for liver transplantations. It is in ABG, if the pH is less than 7.3 plus all, means grade 3 or 4 hepatic encephalopathy, INR more than 6.5 and create more than 3.4 milligram per deciliters. It is the criteria for liver transplantations. Now let's see the match the following. We have column A and column B. Primary organ affected by PCM toxicity, it is the liver. First line treatment for PCM toxicity is the N-acetylcysteine. Metabolite responsible for liver damage in the PCM toxicity, it is the N-acetyl P-benzoquinone imine. Common early symptoms of PCM overdose is the nausea and the vomiting. Ideal time window for NAC effectiveness, it is the within 8 to 10 hours. Now let's see some fill in the blanks. Paracetamol is the primary metabolized in the liver, where it converts into a toxic metabolites called NAPQI. In case of PCM overdose, the toxic metabolites, that is NAPQI, binds to the cellular proteins, causing oxidative damage and the liver injury. The standard maximum daily dose of the paracetamol for an adult is 4000 milligram or 4 gram, and exceeding these limits increases the risk of liver failure. The antidote for PCM toxicity, NAC, works by replacing glutathione in the liver, which detoxifies NAPQI and protects against hepatotoxicity. The Rumac-Matthew nomogram is used to predict the risks of liver injury based on the paracetamol concentrations in the blood since ingestions. Chronic alcohol use increases the enzyme CYP2E1, which increases the productions of the NAPQI and heightens the risk of liver damage in the PCM overdose. A patient present within 6 hours of the PCM overdose with the serum level of the 85 mcg per ml, according to the nomogram, the patient is higher risk of the liver damage and should receive NAC therapy immediately. The hepatotoxic effect of the PCM overdose and the dose-dependent and early treatment with NAC can prevent progression to the liver damage, liver failure. In severe cases of PCM toxicity or liver transplant may be required. King's College criteria, we know that. If acute liver failure progresses, for optimal effectiveness, NAC should be administered within 8 hours of the PCM injections, with maximal benefit observed if given within 10 hours.